Okay, we are recording and passing it to you. All right.
Okay.
Beth, you are all set.
Excellent. So I'm Beth Turnitz. I am the coordinator of the cochlear implant program at Children's Memorial Hospital here in Chicago. And I'm here to talk a little bit today about syndromes associated with hearing loss and talk a little bit more about genetics. I worked the past 10 years at Children's Memorial as a pediatric audiologist. The majority of my time has been spent on the cochlear implant team, but for my first few years at Children's, I actually did work with kids in our diagnostic clinic diagnosing hearing loss. So at that point, I saw children with all degrees of hearing loss, not just severe to profound hearing loss. When Carrie first approached me about doing the talk, I sort of thought, I don't know if I'm the best person to talk about this. I'm not a geneticist. I'm not a physician. But then I realized that probably the information you guys wanted was, how do we work with these kids with the multiple syndromes? What are the parents' concerns? What else may be going on that we're seeing in terms of behavior, other medical complications? And so, I feel like working with many, many families over the years, I do have a good sense of sort of what's going on for them. So I thought maybe this is a good topic for me, and I'm really happy to present to this group. I think it's a wonderful group of parents, and I know you guys provide a really valuable service. Just in case you don't know, Children's Memorial is actually building a new hospital down in more of the heart of downtown Streeterville, and that is what our new building will look like in July of 2012, and we're very, very excited to move in there. So the pre-test, do you want me to read the questions?
Yeah, just like before. Thank you.
Okay, no problem. So the first question is, all genetic hearing loss is part of a syndrome. True or false? The next question is, the following are syndromes associated with hearing loss. A, Alport Syndrome, Charge Syndrome, Brachio-Oto-Renal Syndrome, or Horner Syndrome. B, Alport Syndrome, Down Syndrome, Wolff-Parkinson-White Syndrome, or Usher Syndrome. C, Charge Syndrome, Down Syndrome, Brachio-Oto-Renal Syndrome, and Usher Syndrome. And then D, Down Syndrome, Horner Syndrome, Usher Syndrome, and Brachio-Oto-Renal Syndrome. So again, the following are syndromes. All of the syndromes are associated with hearing loss. Number 3, all patients with Usher syndrome are born with severe to profound hearing loss. True or false? Question number 4. Patients who are interested in determining the cause of their hearing loss should start by contacting their ENT physician. True or false? Question number 5. Which of the following syndromes typically result in conductive hearing loss? Treacher Collins syndrome, Waardenburg syndrome, Usher syndrome, or Pendred syndrome? Okay, so now that we're all done with the pre-test, we're going to continue. I just wanted to start a little bit with a biology review since we're talking about genetics tonight. I just wanted to remind everyone that at least 50% of the hearing losses that are identified in childhood are genetic in nature, and then approximately 70% of those hearing loss are not related to a syndrome. So we're talking about a smaller population. Really just 30% of that 50% of hearing loss that is genetic. And then in most cases with genetic hearing loss, as you most likely know, there is no family history of hearing loss. And a syndrome, I think the way we think about syndromes is maybe that they're a disease or that they're located on a certain gene, which can be true, but actually syndromes are diagnosed by looking at the symptoms or maybe the malformations, depending upon what syndrome it is. that occur together, and then when there's clumps of these symptoms that occur together, then the syndrome is identified. And many syndromes now have been localized to certain genes, but that wasn't always the case. So when several of the symptoms are recognized in a patient, a syndrome is diagnosed. So you have to meet specific criteria in order to be diagnosed with that syndrome. And then again, because now many syndromes have been classified to certain genes, we can do genetic testing, and we're able to see definitively if the patient does have that syndrome. So there are literally hundreds upon hundreds of syndromes that are associated with hearing loss, or that have hearing loss as one of their symptoms. And there's way too many to talk about tonight. So what I did was I tried to pick some of the more common ones that families that you're working with may have the diagnosis of, as well as some of the ones that I think are really notable, and that I've worked with patients with over the years. So this is a list of the syndromes that we're going to be talking about tonight. I'm going to go through them one by one in sort of the same format, so that you can learn about each of them, and just give just a little overview and some information. So the first syndrome is Alport Syndrome, and the characteristics of Alport Syndrome are renal involvement, hearing loss, and vision disorders. So these patients have kidney problems as well as a hearing problem and possibly a vision problem. And the prevalence of Alport Syndrome is 1 in about 50,000 when you look at the general population. With all of the syndromes that I talk about, I'm going to show a picture of someone affected by that syndrome, and the syndrome is from the Alport Syndrome Foundation website. You see that most of the people in this picture are actually older adults, and that's because this syndrome doesn't onset until the teen years typically. The hearing loss is progressive in nature. It typically starts in height with the high frequencies. So you sort of have that sloping hearing loss and then sort of progresses and flattens out across the board. Again, late childhood or early adolescence, so preteen, teen years, which is, as you know, a really hard age to be dealing with, accepting the fact that you have a hearing loss now and maybe you have to wear hearing aids. And then typically the patients affected are males. They're not typically females. In terms of an additional resource, that would be alportsyndrome.org. So I think that these are teens that deal with all of the adjustment problems that teens have, as well as having to deal with the fact that they now have this hearing loss, and it's part of the larger syndrome, which may lead to even more medical complications. And so definitely something to think about when working with these families. So I wanted to mention, too, that all of my pictures were taken from the Internet, so if you happen to know someone in any of the pictures, I didn't get them from families that I've worked with. They're all, I did a Google search for all the different syndromes, and these are the pictures that I came up with. So Brachio-Oto-Renal syndrome is our next syndrome, and the characteristics are bronchial malformations, which is a malformation in the developing fetus, that is, it results in a clefterocyst in the neck. And then you can also see a cupping of the outer ear, ear pits or skin tags. All of those things develop around the same time in an unborn child. Kidney malformations and hearing loss. The prevalence is 1 in 40,000 to about 1 in 70,000. So again, they don't know the exact prevalence, so that's sort of the ballpark range. And this little boy has Brachio-Oto-Renal syndrome, and his family, you'll see, is one of my resources. They actually started a foundation for Brachio-Oto-Renal syndrome. There's not a lot of information out there about it. More than 90% of children diagnosed with Brachio-Oto-Renal syndrome have some form of hearing loss, and the type can vary. It can be mixed, so a combination of conductive and sensorineural. It can be purely conductive, or it can be purely sensorineural. And it can range from a really mild hearing loss to a profound hearing loss. I know children with this syndrome that are cochlear implant patients, and I know children that really have very minimal hearing loss that have this syndrome. It can be congenital, or it can be progressive in nature, so we can see a progression in the hearing loss over time. Like I mentioned, that little boy, I think his name is Kane, and his family started the Kane Foundation to get some information about Brachio-Oto-Renal syndrome out there. It's a really great website if you're working with a family in terms of they have message boards where there's blogs from dads whose kids have Brachio-Oto-Renal syndrome. There's information about support all over the country for this syndrome. But, in terms of the medical information, I would go more towards the facesofchildren.org. I really wanted to give everyone websites so that if you're working with a family with this syndrome and you want to find out more, or the family wants to find out more, you have more information on where to go. The next syndrome is CHARGE syndrome, and CHARGE syndrome is near and dear to my heart. There are many, many patients that have severe and profound hearing loss that have CHARGE syndrome, and I work with several families that have children affected by CHARGE syndrome. The effects of CHARGE syndrome can be really pretty wide-ranging in the scopes of medical problems, and CHARGE syndrome is actually an acronym. That's why it's all capitalized. So it stands for all of these different things that I have listed out below. But basically, these children a lot of times have significant vision problems, significant cardiac issues, coronal atresia, so that's choanal atresia, which is some breathing problems, retarded growth, so they're typically much shorter or smaller in stature, and then genital abnormalities, and then ear abnormalities, so not only the hearing loss, but also abnormalities of the external ear, which can make keeping hearing aids or cochlear implants on particularly challenging in these patients. The prevalence is actually 1 in 8,500, so smaller than the other, or larger, I guess, more frequent than the other syndromes that we've seen tonight. And this little girl has CHARGE syndrome. The hearing loss of CHARGE syndrome can vary. It can be sensorineural or conductive, and again can vary from mild to profound. I've seen patients with CHARGE syndrome, many of them, who've had progressive hearing loss over the years, so it can absolutely be progressive. And if it's conductive, the conductive component can fluctuate. A lot of these patients, in addition to hearing loss, have an abnormality of the auditory nerve, so most likely that's what caused the hearing loss, is the abnormality of the auditory nerve as a result of the CHARGE syndrome. And what can be challenging is that sometimes they're told that they're not cochlear implant candidates, or they aren't cochlear implant candidates because the auditory nerve is either too small or too absent in order to really make use of any stimulation from the implant, or they're told you're a cochlear implant candidate, but we don't really know what it's going to do for you. So maybe we'll get lucky and it will stimulate the nerve and everything will work great, but there's a chance that it may not work at all, which is not typical if you have a normal functioning auditory nerve. So absolutely, in addition to all of the other multitude of medical challenges these families are dealing with, the hearing devices aren't maybe as straightforward as they are for some other families. So again, you have the challenges of retention, you have the possibility of having the abnormal auditory nerve, in addition to just the general worries about progression or fluctuation. The additional resource for CHARGE syndrome is the chargesyndrome.org, which is the CHARGE Syndrome Foundation website. And this is a great organization. I actually had the pleasure of speaking at their national meeting a couple of years ago when it was held here in the Chicago area. We have many parents that are on the board or participate heavily in the foundation, and I think it's a really great resource for families. So if you have families that have CHARGE syndrome, I think that it's absolutely worth referring them. The families that I know that have CHARGE syndrome have all met through the foundation, and it's great for the kids to see other kids that have CHARGE. It's great for the parents to talk to other parents, as you know, and it's a really strong and active organization here in the Chicago area as well as throughout the country. Down syndrome is the next syndrome we're going to talk about. So the technical name for Down syndrome is trisomy 21. I think everyone is pretty familiar with the characteristics of Down syndrome, and this little girl is super cute that is affected by Down syndrome. She had the characteristics are developmental delay, the flat nasal bridge or nose, then the protruding tongue. Congenital heart disease is a big concern or complication of Down syndrome. And then hearing loss is really common in these patients, and the prevalence here is 1 in 600 children in the general population are affected by Down syndrome. Hearing loss occurs in about 40%, all the way up to 80% of patients, and the reason why I think that the numbers are so varied is it depends upon what study you're looking at, if they're counting transient hearing loss, so hearing loss caused by fluid behind the eardrum, from ear infections, or are they only counting, more of a permanent hearing loss, whether it be conductive or sensory neural. So I think that's the difference in the 40% and the 80%. It is typically conductive, but it can be sensory neural or mixed. And it's due to, it can be due to the congenital middle ear abnormalities, which would give you a conductive loss. But more common if you have a conductive component or conductive hearing loss and you have Down syndrome is that, again, it's a recurrent otitis media or ear infections causing fluid behind the eardrum. The latest statistic that I read said that patients with Down syndrome are 17 times more likely to have tubes than someone in the general population. So if you think about what that means in terms of the number of ear infections, it gives you a really good idea. So 17 times more often patients with Down syndrome are getting tubes than patients in the general population. And then the additional resource for Down syndrome is the Down syndrome website, the National Down Syndrome Foundation. Goldenhar is a syndrome that presents with craniofacial abnormalities. Typically, these patients have a cleft lip or palate, or cleft lip and palate. Eye anomalies. There can be some neurological defects. You can have skin tags around the ears. Oral atresia, which is the complete absence of an external ear and ear canal, so literally just a flat, smooth place where the ear would normally be. And then, of course, hearing loss, and many times due to that, oral atresia. And that atresia can be unilateral or bilateral, so one ear or both ears can be affected. The prevalence of Goldenhars is 1 in 5,600. And this little boy right here has a pretty typical presentation of Goldenhar. The hearing loss is typically conductive. Again, that oral atresia would cause a conductive hearing loss. So the external ear and the middle ear maybe aren't formed fully, but the internal ear is. But it could also be sensory neural in nature. And we do have patients with Goldenhar that had cochlear implants. Hearing loss occurs in over 50% of the cases. So typically, if you have Goldenhars, we're going to have a hearing loss, and it can be caused again by abnormalities of the external or middle ears. These patients are great bone conduction hearing aid patients, or BAHA, the implantable bone conduction device, because if they have normal inner ears, they do really, really well once we can get that sound to the inner ear. The additional resource here is goldenharsyndrome.org. Jervell and Lange-Nielsen syndrome is a scary syndrome, and I didn't include it to be scary, but I think it's important for people to know about. The characteristics are a heart problem. It's a cardiac conduction defect is what they call it, or a prolonged QT interval, meaning that on the EKG there's a longer period between where they mark a Q and where they mark a T than for someone with a normal heart and heart rhythm. And then congenital hearing loss. And those are the only two characteristics of Jervell and Lange-Nielsen syndrome. And it's profound. If they have a hearing loss, it will be profound. If they have Jervell and Lange-Nielsen syndrome, they'll have profound hearing loss. The prevalence is 1 to 6 in a million. So literally like 1 in a million patients in the general population have Jervell and Lange-Nielsen syndrome. This family, I think, is a great story about Jervell and Lange-Nielsen syndrome. So the little baby, you can see, has the ear molten, and she has hearing aids. And she was born profoundly deaf. And when they went to do all of their genetic testing to try and find out what caused the hearing loss, they determined that she had Jervell and Lange-Nielsen syndrome. And so she's been put on medication now so that the cardiac problems won't be a problem for her. But because of this, they got other members of their family tested. So if you have Jervell and Lange-Nielsen syndrome in your family, there can be sort of a sister or cousin disorder that can cause heart problems that aren't accompanied by profound sensory neural hearing loss. And so they actually found that there were several other people in the family that had cardiac conditions that were undiagnosed. And if they had gone untreated, they could cause significant heart problems, even death. And so this little baby basically saved all these people's lives in her family, and that's what this mom wrote on her blog when she was blogging about it. That's where I got the picture. But that is what makes Jervell and Lange-Nielsen syndrome so scary, is that the cardiac problems that are caused by this syndrome really can be deadly. And so one of the things that we'll talk about later when we talk about learning the cause of the hearing loss is testing for Jervell and Lange-Nielsen syndrome. So if the immediate diagnoses are ruled out, then Dr. Young at our facility will always order an EKG just to rule out Jervell and Lange-Nielsen syndrome, because it's definitely not something you want going undiagnosed. Again, because it is a 1 in a million condition, there's not a lot of information out there, which is why there's this really long web address. But this information is from the National Institutes of Health. It's good information about the syndrome if you want to learn more. Neurofibromatosis type 2 is another sort of scary disorder. Its characteristics are tumors of the central nervous syndrome, and it typically includes bilateral tumors on the acoustic nerves. In most patients, these symptoms begin in the teens or 20s, but there are patients who maybe don't present with this until age 30. So, normal developing, everything's going fine, and then all of a sudden, can't hear in one ear, find out that there's a tumor on the auditory nerve, and then, can't hear in the other ear, and then there's a tumor on the auditory nerve, and then unfortunately the tumors continue to spread throughout the body. The prevalence of NF2 is 1 in 25,000. And this woman has a really great story about how she went deaf from NF2 in high school and how hard that was for her. And hearing aids and cochlear implants don't typically help with NF2 because of the tumors on the auditory nerve. And so she learned sign language in high school, and now she's like that and doing really, really well. Again, this is another disorder that onsets in the teens, which is a particularly challenging time. And again, it's typically unilateral and then progresses to bilateral. It is progressive, and it typically starts as mild and then becomes worse and worse and worse. And not only does the detection of sound become worse and worse, the threshold, but actually discrimination, so the word understanding becomes much worse. And it presents differently in every patient. So I had a family where both patients had NF2, and one of them got a cochlear implant, and she can talk to you on the phone, she can talk to you if you turn around. She does really, really well with her implant. And the other young man got a cochlear implant and really doesn't understand speech with it at all because of where the tumor is on the auditory nerve. So I think that it can be a big challenge to go from having normal hearing to really not being able to communicate without sign language. And then in addition, because the fact is that you can have the tumors throughout the body, there can be other medical complications as well. And then I did find a great resource for that as well. That's actually where I found that young woman's story that I was talking about before. And that's the nf2crew.org. So if you do have a family that's dealing with it, it looks like that's a great website. Pendred Syndrome is the next one we're going to talk about. And its characteristics are hearing loss associated with abnormalities in the temporal bone, which is like the ear bone on the skull, which is basically either enlarged vestibular aqueducts or wide vestibular aqueducts. They're the same thing. People use the term interchangeably. Sometimes people even say large vestibular aqueducts. They all mean the same thing, which just means that there's an abnormality within that ear bone. And then with Pendred syndrome, you're born with that abnormality, and then later you can develop a fibroid goiter. If the it's not typically a problem that we have in this country, but because of the iodized salt, but it is something that could happen. The prevalence is unknown, but it's thought to be about 7.5% of patients with hearing loss. So just to give you an idea, it's actually a relatively high percent. This little girl has Pendred Syndrome. The hearing loss is typically from birth, although I have seen it progress a little bit later on in life, and it's bilateral. It's typically severe to profound, but I've also seen many a patient where it's mild to moderate and then can progress over time. Fluctuations in progressive hearing loss are common. The degree of hearing loss when we first meet the patient can be very different. Pendred syndrome is diagnosed once the patient has the CT and the temporal abnormalities, the right vestibular aqueducts or large vestibular aqueducts are diagnosed. Then the testing for Pendred syndrome is completed, and it is a simple blood test that's on a way to a lab and analyzed. And again, there's not a ton of information out there on Pendred syndrome, so the best place to go is that National Institutes of Health website. Treacher Collins is the next syndrome, and I've worked with a lot of Treacher Collins patients over the years, so it's kind of amazing to see that the prevalence is 1 in 50,000. But the characteristics are craniofacial abnormalities, malformed ears, cleft palate, hearing loss, and then hypoplastic or absent thumbs. The hearing loss is typically conductive, again, due to those malformations of the outer ear. And the patient that we just saw back there was actually wearing a bone connection processor or headband. And these patients, as well as when we were talking about the patients with Goldenhar syndrome before, because of that permanent conductive loss, are really good bone conduction hearing aid or bone conduction implant patients. The hearing loss can be unilateral or bilateral and can be flat or sloping, so a little bit different in terms of configuration, but it is typically conductive. And then additional resources that craniofacial website with a lot of the disorders or syndromes, and that is the website for Treacher Collins. Usher syndrome, the characteristics of Usher syndrome are hearing loss and then retinitis pigmentosa. And then there's 3 types of Usher syndrome. So the retinitis pigmentosa is a vision disorder, and it starts out with patients losing their peripheral vision, and then over time they lose more and more vision until typically they end up with some sort of tunnel vision, which I think is really hard. Then you're losing 2 senses. And so these patients, a lot of times when I've worked with families that they're feeling okay with the hearing loss, but maybe they're concentrating more on the vision loss at that time. There's 3 types of Usher syndrome. The first is congenital severe to profound sensory neural hearing loss, who develop retinitis pigmentosa by age 10, and then absent vestibular responses. So frequently these patients don't walk until they're 18 months or older, and case history is actually what gives us a tip-off in the beginning that this patient may have Usher syndrome, is that the parents will report that they're a really late walker, so 18-plus months. Type 2 is these patients are born with moderate to severe sensory neural hearing loss, and then the retinitis pigmentosa doesn't onset until a little bit later in life. And then type 3 has a progressive hearing loss with a progressive vestibular involvement, and then those patients can have a variable severity of the retinitis pigmentosa. The most common type that we see is the type 1, at least in the cochlear implant program at Children's, which makes sense because those are the patients that we would expect to see. The prevalence is 2.5 to 4.5 in 100,000. Again, the type of hearing loss that you have determines which category of Usher syndrome that you're placed into, but it can be congenital or progressive. It can be moderate to severe or severe to profound. There's a lot of research going on with Usher syndrome, and there's a lot of families that I've worked with in the area that actually travel to facilities in the East where they're doing a lot of research on Usher syndrome, particularly on how to combat the vision disorder of the retinitis pigmentosa. And then UsherSyndromeFoundation.org is, again, a wonderful resource. Waardenburg syndrome. The characteristics of Waardenburg syndrome, and there are 4 types of it. are hearing loss, changes in pigmentation of hair, skin, and eyes. So you can have the bright blue eyes are the typical hallmark of Waardenburg syndrome, but you can also have a different color in each eye, so a blue eye or a green eye. Or you can have different colors in the same eye, it's actually blue and green in the same eye. The Hirschsprung disease, which is a bowel disorder or intestinal blockage. The wide-set eyes, and then a white forelock, again, is sort of the classic Waardenburg presentation, although I've never actually seen a patient with a white forelock in person, and I've worked with a lot of Waardenburg patients. Type 1 can have all of the above characteristics. Type 2 only have the hearing loss and the pigmentation, so the hair and the eyes abnormalities. Type 3 have all the characteristics above and upper limb abnormalities. And then type 4 have the pigmentary abnormalities, the wide-set eyes, and the Hirschsprung disease. The prevalence is 1 in 20,000 to 1 in 40,000. And the hearing loss is typically congenital profound bilateral, but it can vary in nature and can actually be unilateral. And I've worked with patients with a unilateral presentation of Waardenburg syndrome as well. Although, again, most commonly we see a bilateral severe profound hearing loss. With Waardenburg syndrome. I just thought this little boy with the cochlear implant was really cute, so I put him on here. I thought this woman's story was very interesting. She has Waardenburg syndrome. She lives in London, and she's actually apparently a very popular actress on a deaf soap opera that they have over there, which I thought was really cool. So apparently there's a very popular deaf soap opera on the BBC, and she is one of the main characters on it. I like that picture as well because you can see the classic white forelock as well as each of her eyes is a different color. I don't know if you can see it well on your computer screen, but one is blue and one is green. Okay, so those are all the syndromes. I feel like alphabet soup, it was sort of a long list, but I'm glad that we were able to talk about them. And again, it's really just a sampling of the different syndromes and the different things that can be that families can be working with as well as the hearing loss. There are many, many other syndromes out there that I didn't touch on today. But one of the other questions that came up was, what about Connexin? So you may have heard about Connexin. The Connexin 26 gene, or the JBJ2 gene, is the most common cause of the non-syndromic hearing loss. So remember, if we're saying 50% of hearing loss is genetic, and then only 30% of that is syndromic, so 70% is non-syndromic. Connexin 26 is the most common cause of that 70% of the non-syndromic. And approximately half of that non-syndromic or recessive hearing loss is caused by mutations in this gene. The recessive, again, you have to have both parents being a carrier. And the child has to inherit both genes in order to exhibit the symptom, or in this case would be hearing loss. The typical process for determining the cause of hearing loss, that was just my basic wrap-up on Connexin. So next is, how do we determine the cause of hearing loss? So how do we know if it's Connexin or if it's a syndrome or something else? It's by exclusion. There's not a great way to do it. So basically you start with what's the most likely. So if there's no one else in the family affected by hearing loss, and we know that half of the hearing loss out there is genetic, and most of that is caused by Connexin, we'll start with looking at Connexin. And then if the patient is Connexin negative, then the next thing is that we'll do typically a CAT scan. And if there are wide vestibular aqueducts, the patient will be tested for Pendred Syndrome, because we know that that's the cause of the hearing loss, is the wide vestibular aqueducts or the large vestibular aqueducts. So whether Pendred Syndrome is present or not, that's the cause. If their CT looks normal, then the next thing would be looking at the EKG to make sure that Jervell and Lange-Nielsen syndrome isn't present. And then you sort of go from there. Obviously, if the patient's diagnosed already with another syndrome where we know hearing loss is a characteristic, that's going to be the cause of the hearing loss. So it really is based on just looking at what can we exclude, what do we know that it's not. So if the patient doesn't present with any other diagnoses, no craniofacial abnormalities, we know it couldn't be Treacher Collins or Goldenhar syndrome, and we go from there. We base on the case history. So again, if the patient presents with bilateral profound sensorineural hearing loss, and they are now 20 months and just starting to walk, the first thing you might think is Usher syndrome, and so testing would be done for that. The diagnosis of Usher syndrome is actually made through a vision test, so in combination with the congenital profound sensorineural hearing loss. If the vision test reveals that the patient has retinitis pigmentosa, even if they're not exhibiting any vision disorders at that point, but the testing reveals that they do have that retinitis pigmentosa diagnosis, then they would be classified as Usher syndrome. So again, other medical diagnoses are how we sort of determine that cause. And then that's the typical flow of testing, what I sort of talked through. So start with the most obvious and work our way down the list as we're ruling out things. So one of the questions that also came up was who should families go to if they have a diagnosis of hearing loss, but they have no idea what was the cause of the hearing loss or the etiology. Who should families see? And many of these tests can be done by the otologist. I have Dr. Young on here because she's our otologist at Children's. But if they're working with Dana Suskin at University of Chicago, or if they're working with, Dr. Hoteling at Loyola, then that would be where I would start, because many of these tests may have already been done. They might have already had a CT to rule out wide vestibular aqueducts, or the Connexin testing and Pendred Syndrome testing is a quick blood draw in the office. So I would start there rather than start with the genetics department. But if for some reason the family doesn't feel like they're getting answers from their ENT, or if the ENT has done a lot of this testing and you can't determine the cause, then the next step would be to go to the genetics department. The other thing would be if there's a cause already determined, but the family wants to know, I'm thinking about having more children, what are my odds, what are my chances? That would be, again, going to the genetics department and getting some genetics counseling. So again, there's the number for our hospital genetics department. One of the things to think about in this era of healthcare is that frequently you need a physician order before you go to a specialist. So that's why it's also important to work with your ENT in the beginning, because if they can't determine the cause, they should easily be able to give you that referral to the genetics department, or give the family the referral to that genetics department. But if for some reason they can't get that from their ENT, they can get that from their primary care physician as well. And they can just call, because sometimes you need a physician order for some things, and some insurances do, and sometimes you don't. So one of the things that's always frustrating to me is that I feel like we do the blood draw for Connexin, and then we wait, and we wait, and we wait, and we wait. And it actually takes a couple months to get the results back. And I know that if it's frustrating for me, I know it's really frustrating for the family. And so one of the questions I asked was, well, why does it take so long to get the results? And the answer is there's a couple different things. So there aren't that many labs in the country that perform this testing, and that's what I thought. I thought it was just like, a backlog of, the blood sitting there waiting to get tested. But that's actually not the only reason why it takes so long. The reason why is that they do batch testing. So because when they run the test, they have to test in batches of blood. They have to wait for a whole bunch of test samples to get sent in. So if they just did a whole big batch test and your sample comes in next, they may be waiting, a full 2 months in order to get that sample analyzed. It also takes time. The way that they break down the blood, they do it in stages, and so as they're breaking it down, they actually have to wait for things to happen before they can analyze it and go on to the next stage. And even some of the labs that do the testing, if things are looking really strange, they actually send the blood to other labs. So it does really take a long time. We don't expect that time to get shorter. Expect it to stay the same unless somebody comes out with a breakthrough in how you can do this analysis. So the typical turnaround time for Connexin testing or Pendred testing is 2 months. And that's the lab that we use. We use a lab in Iowa, so there's not even a lab in Illinois that we use that does this testing. I wanted everybody to have the references. The nice thing about working with syndromes is they don't change a ton over the years. So, my textbooks are all from relatively recent. I did draw a lot of information from textbooks as well as from the internet, which are those different websites listed. I did get some information from there if it wasn't something I was able to find either through a textbook or on PubMed. And then here are all the pictures of the wonderful kiddos that we saw. Okay, any questions before the post-test? Okay, here's the post-test. Question number 1. All genetic hearing loss is part of the syndrome. True or false? Question number 2. The following are syndromes associated with hearing loss. A. Alport Syndrome, Charge Syndrome, Brachio-Oto-Renal Syndrome, and Horner Syndrome. B. Alport Syndrome, Down Syndrome, Wolff-Parkinson-White Syndrome, and Usher Syndrome. C. Charge Syndrome, Down Syndrome, Brachio-Oto-Renal Syndrome, and Usher Syndrome. Or D. Down Syndrome, Horner Syndrome, Usher Syndrome, and Brachio-Oto-Renal Syndrome. Question number 3. All patients with Usher syndrome are born with severe to profound hearing loss. True or false? Question number 4. Patients who are interested in determining the cause of their hearing loss should start by contacting their ENT physician. True or false? Question number 5. Which of the following syndromes typically result in conductive hearing loss? A. Treacher Collins Syndrome, B. Waardenburg Syndrome, C. Usher Syndrome, D. Pendred Syndrome. And I think that's it. Feel free to contact me if any questions come up. That is my email address. That's my direct line. You can also give my information to a family. That's fine with me. And then I also wanted to put our website on here. We recently updated it, so if there are questions about what services are offered at our center, that's always a good place to look.
Thank you so much.
Yeah, no problem. I didn't get a chance to look at my slides today, so I hope it was